All righty, I'm going to go ahead and get started because it is 11:30. Happy Wednesday to everyone. And yes, I am recording, so we should be good. Okay, so there was a question about the practical. Are you going to be able to go and see exactly what the answers were, what you got wrong, what I gave you credit for, all that kind of stuff? I had completely forgot to go back in and make all that stuff available to you. Thank you very much, Jackie, for reminding me of that. And so now I have changed the test options where you should be able to go back into your practical and see what you were marked wrong for. And if I went in and overrode the computer, what you'll see is, like, let's say you misspelled something, but it was close enough, I gave you credit for it. It'll be marked wrong, but where it says the points, you'll see that you actually got the points. That basically means I went in and I overrode the computer. So you go to your grade center, and you should have a link where you can click onto your grade, your score, and then it should open up the practice. Then you should be able to view at your attempt, as it's called. Okay, let's cover a couple of announcements and then finish up cardiovascular system. Okay, so this is sort of a review, but I just want to remind you, tomorrow you will have your third exam. It will open at 8 a.m. It will close Friday at midnight, but don't wait until the very end to do that. Okay, don't wait until Friday night. It will cover the muscular system. Please mute your mic, please. Please mute your mic. It will cover the muscular system, the endocrine system, blood, and the cardiovascular system. The questions will be true and false and multiple choice questions only, and it's split 25-25. I split the exam into two parts, part A and part 1 and part 2. It doesn't matter which order you take them. It just gives you, only requires you to sit for 25 minutes. You can go take a break and then come back. Okay, the questions are displayed one at a time, and there is no backtracking. So once you submit your answer, you will not be able to go back and look at previous questions and answers. Bear with me just a second. I see there was Okay, is there a question? Thought I heard the little question thing. Let me see. Oh, no worries. Okay. Right. Okay, just also want to remind you, there is a pre-lab on the functional anatomy of the digestive system that closes Friday at midnight. So what you should be doing is working through this week's lab, which includes your watching a video that another instructor put together on the digestive system, and then we're using those Quizlets to practice and learn the anatomy of the digestive system. Quite a few structures, so you want to get on that as soon as possible. Lab exam covering anatomy of the heart and gross anatomy of blood vessels closes at midnight on Friday as well. So don't forget to do those. Also, I posted your take-home exam. I know many of you have been waiting for that. It is now posted. It's in the assignments section of Blackboard, just like where all of your other quizzes and exams are. Now, with your take-home exam, you can open it as often as you like. So you can go in and answer 5-10 questions and then leave and then come back and add more and then leave and come back and add more. At least that should be how it works. If you want to test it to be sure, you could go on, answer one question, then leave and then come back and make sure it's saving those. But that is how it should work. However, okay, Michelle said that's how it worked for her. Awesome. But you do not want to submit until you have entered everything, because if you submit and decide, oh, I want to change question 4 and 5, I believe you have to resubmit everything. I think once you submit, it's not going to save your answers, and if you wanted to get a higher grade, you'd have to re-enter everything again. Now, you can submit your exam as often as you like. And so if you submit your exam and you get an 80 and you're like, oh, I can do better than that, I think I can get an 85, and you want to change some answers and submit it again, you can do that, but you have to key in all 100 answers again. So you don't want to work it that way. You want to enter your answers, get with other people and discuss the material and make your changes before you submit, because once you submit to submit again, you have to enter everything again. Okay. It's not due until May 8th at midnight, and that should be a Friday. Okay. No, the take-home exam is so I handed the take-home exam out to you, and it was 100 multiple choice questions. So you actually should have a physical copy of that exam. Okay, it's the exact same exam I handed out to you, and the exact same one that was on Blackboard as well. It's just that because we've gone online, you have to enter it through Blackboard, whereas the intent was originally it would be a Scantron that you'd give to me, and then I'd grade. Okay, is that clear with everyone? If you have questions about that, stay after the class is formally over, and I'll try to address any questions that you have. If I need to email you the take-home exam or show you where it is on Blackboard, I'll be more than happy to do that. Okay? Before we continue talking about the cardiovascular system, I want to talk about our next organ system, which is the digestive system. Now, the digestive system will not be on tomorrow's exam, so I just want to make sure that is clear. If I finish the cardiovascular system and we have time, I'll start the digestive system. But the digestive system, originally, when I teach this class face-to-face, I teach the digestive system in a flipped format. What that means is students would actually watch videos on the digestive system outside of class, and then when you came to class, I would discuss the material. So all of these lectures are actually online, and you can view them. If I finish and have enough time today, I am going to lecture on the overview of the digestive system. If I don't, it is on Blackboard. It's 16 minutes and 22 seconds long. If I don't get to it today, please watch that screencast by Friday. Also, I will not get to the oral cavity, pharynx, and esophagus today. So even if I get to overview of the digestive system, watch this screencast on your own. Okay, so you are expected by Friday to have covered overview of the digestive system and and the oral cavity, pharynx, and esophagus. It's only about 40 minutes, but I need you to do that because we're a little behind. Okay. Oh, excuse me. I said that wrong. If I don't get to overview of the digestive system today, watch overview of the digestive system on your own. If I do, that's great, and then I'll cover the oral cavity, pharynx, and esophagus on Friday. Over the weekend, if I don't get to the stomach, then I want you to cover that yourself, and also cover anatomy of the small intestine. So whatever I don't get to today and Friday, you need to cover through anatomy of the small intestine. And then on Monday, I'll cover digestive system, digestive physiology of the small intestine and the large intestine. And let me show you where this is right quick, because that's important. Bear with me real quick. Chrome. Okay, so this is your lecture folder. So if we just scroll down to the digestive system and you click on that, what you're going to see is first, here's the lesson outline. outline. And so what it has is a list of each of the screencasts, how long they are, and the learning objectives. So in other words, what are you supposed to learn from each screencast? It's shown there. Then I have 3 folders, and those folders contain the screencasts. So the first folder here, first are the slides that you can print out if you would like. Then there's the actual screencast, and when you click on that, it'll open up. It's the same format that your last practice practical was. This screencast provides you with an overview. This screencast was designed. Okay, you're not going to be able to see it on, but anyway, it's we obtain the nutrients that we need. But anyway, once you open it, I start going through the content. The very first thing I do is I tell you the learning objectives like I do in class. Then I go through the content, and at the very end, I review the learning objectives. Okay, so here are the slides. Now, after the screencast, I have a couple of self-tests, which gives you the ability to sort of self-test yourself on the material. So if you're wondering, hey, did I understand? Did I get the main points? Did I achieve the learning objectives? Take these self-tests, and they'll tell you. Now, I want to be clear, even though the self-tests will give you a score, and even though the score will appear in Blackboard, it in no way affects your grade. Let me say that again, because I always have students that always ask this question. First, the self-tests will give you a grade, so you will get a grade, but that's only so you know if you're getting it or not. It will appear in Blackboard, but it will not affect your grade. They're simply to be used as self-assessment tools, your ability to figure out, did I get it or did I not get it? Okay, so I want to make that clear. The first self-test you can take over and over and over again. The second self-test, you can only take it once. And the reason why I have it that way is because I don't want students memorizing answers and thinking, okay, I got it because I memorized the answer. You take the first self-test, you don't do well at it, you go back and you look at the slides, you look at the screencast again, right? Then you can take the self-test again and say, okay, I think I have this, then take the second self-test. If you're still getting questions wrong, right, it means there's something you're not getting, and you need to ask me or ask another student. You don't need to just simply keep taking the test until you get the answers right and you memorize the answer. That doesn't help you. Okay, so that's how these self-tests are intended to be used. They are to help you assess your knowledge of the material. They will not affect your grade in any way. Okay, so for every screencast, there are the slides, and then there are the self-tests. Okay, and again, some of these I will go over in class, and then others you are expected this weekend to cover on your own. Okay, so what we're going to do today is we're going to finish the cardiovascular system, and if we have time, and only if we have time, we will move to the digestive system. All right, so we finished our discussion on all the factors that can affect blood pressure, and we said that our formula for blood pressure was blood pressure equals cardiac output times peripheral resistance. And this figure from your book summarizes all the different factors we talked about that can affect blood pressure, either by affecting cardiac output or by affecting peripheral resistance. Okay, and so I covered everything that you're responsible for knowing in terms of on the exam on tomorrow. But I do want to talk a little more about blood pressure. Okay, well, there are a couple of things I do want you to know that we haven't covered, and they're shown here. Explain systolic and diastolic blood pressure and how they're reported. Describe how a sphygmomanometer is used to determine blood pressure, and describe hypertension and hypotension. So first of all, blood pressure is one of those signs that are used to determine if someone is cardiovascularly stable. Your vital boy, I'm losing the words here, not symptoms, but vital signs include your blood pressure, your heart rate, your respiration rate, as well as your temperature, right? Those are typically taken when someone enters like the emergency room, the first thing they take, and then they decide whether you need to be seen immediately or you can sit and wait, okay? So blood pressure, we have systolic pressure, which is pressure in arteries at the peak of ventricular contraction or ventricular systole. And then there's diastolic pressure, which is pressure, the lowest pressure when the ventricles are relaxed. It is measured over millimeters of mercury. Normal is below 124 systolic and below 80 for diastolic, and it's always reported systolic over diastolic, so it's always the higher number over the lower number. And typically the method that is used for determining blood pressure is called the oscillatory method, and basically you're listening to the flow of blood. And then here's how it works. Now, we've all had our blood pressure taken before, and you're probably wondering, what was the clinician listening for? And I've taught some students that know how to take blood pressure, but they really didn't know what they were actually hearing, and so some of you may be in either of those camps. So let's talk about how blood pressure is actually taken. So typically it's taken in the brachial region, in the arm. So here we have an individual with blood flowing through their brachial artery. So typically a sphygmomanometer is used to assess blood pressure. It has a pressure cuff, and it has a tube with a little rubber ball that's used to inflate that pressure cuff. So we place that pressure cuff around the brachial region, and then we start pumping it, and we take a stethoscope and place it below the pressure cuff, and basically we're going to listen to the presence or the absence of the flow of blood. So if we inflate that pressure cuff such that the pressure is above the systolic pressure of the patient, there's not going to be blood flow, and we're not going to hear anything. If we then begin to deflate that pressure cuff, we're going to, as soon as we get below systolic pressure or hit systolic pressure, there's going to be a little blood that starts to move through, and it's going to be turbulent flow, and we're going to be able to hear it. I want you to think about if you've ever taken a water hose and bent it so that there was no water that goes through it. You don't hear anything. If you then begin to open up that unbend it a little bit, and a little water goes through, you hear it go shh, like that. Well, if you start to allow a little blood to spurt through, you can hear that with the stethoscope. And at that point, you mark systolic pressure. You then continue to deflate the pressure cuff. And when you hit the diastolic pressure, then then you have restored blood flow to the brachial artery, and it's going to be laminar flow, so you're not going to be able to hear it moving through, and so the sounds stop. And at that point, you mark the diastolic pressure. Okay, so we mark systolic and diastolic pressure based on the presence or absence of the sound moving through that that artery. And as Michelle says, you have to make sure you're listening to the right artery. Thank you, Michelle. National Heart Association lists this as their criteria for normal, prehypertensive, and high blood pressure. And this is not something I'm going to test you on. It's just something I want you to be aware of, because hypertension is something that's very pervasive in our society. There is a lot of people who suffer more morbidity and mortality because they're walking around with elevated blood pressure. So normal is less than 120 for systolic, less than 80. For diastolic, you're considered pre-hypertensive if you're between 120 and 139, and 80 and 89. If you're pre-hypertensive, this is where typically you're not issued provided medication to treat that, but you're told maybe you need to lose some weight, you need to eat more healthy, you need some type of intervention, or I shouldn't say intervention, changes to lifestyle to prevent you from becoming hypertensive. And if you get above 139, you are considered hypertensive, or 90 for diastolic. And certainly as you go higher and higher, it becomes more critical, more damage is going to be done to arteries. And if you have a very high blood pressure, that can actually lead to rupture of a blood vessel, and depending on what blood vessel it is, that can lead to aneurysms, cerebral vascular accident, all kinds of emergency medical situations. Now, it is normal for blood pressure to be elevated during a fever, or doing physical exertion, or if you're emotionally upset. So if you ever have your blood taken, your blood pressure taken while you're actively sick, even if you don't have a fever, or if you have a fever, right, that can elevate your blood pressure. If you're emotionally upset, if you just climb some steps to get to the second floor because that's where your physician or clinician sees you, all of that can elevate your blood pressure. So just keep that in mind. Make sure that if you do go to have your blood pressure taken, that you haven't climbed steps or done something that's upset you recently, or at least if you have, when they take your blood pressure, you can contextualize your results. Hypertension is considered sustained, persistent systolic pressure above 139 and diastolic above 89. Blood pressure is often referred to as a silent killer because people can walk around for years with elevated blood pressure and they feel absolutely fine. And 10 to 20 years later, they suffer a heart attack, or they find that they are in kidney failure, or they have an aneurysm that ruptures, or there is arterial sclerosis, that is hardening of the arteries, and it all is because they had untreated hypertension for years. So it is something that one should take seriously. Even if you feel fine, high blood pressure can be causing damage to your body, and if left unchecked, can lead to some very chronic illnesses that can lower your life expectancy. So now we're getting into things I'm not going to test you on, but I think they're important to know. In terms of diet, we've got contradictory suggestions over time, but in general, it is still viewed that diets low in sodium, saturated fats, and cholesterol help reduce your risk of hypertension. 90% of the population of people who are hypertensive don't have any concrete cause that they can point to. Okay? Many people who are hypertensive, there's nothing that they are necessarily doing or anything that has happened in their health history that necessarily is causing the hypertension. So what I want to talk a little bit about are risk factors that increase your risk of hypertension. So we know that obesity, as your body weight increases above what's considered the normal range, that increases your chances of hypertension. We know that over the age of 55, risk of hypertension increases. Males are at higher risk of hypertension than females, at least premenopausal females, because of the blood pressure reducing effects of estrogen. However, postmenopausal females and men have the same risk of hypertension. Certainly, if you have a family history of hypertension, that increases your risk. It doesn't mean that because your parents are hypertensive that you will necessarily be hypertensive, but your risk is greater than someone whose parents aren't hypertensive. And also, if you have a sedentary lifestyle where you don't get a lot of exercise, that also increases your risk of hypertension. So there are a lot of these factors that are within your sphere of influence. Certainly body weight, you can't change your age or your gender or your family history, but in terms of body weight and lifestyle, that is under your control. Hypotensive means below a systolic blood pressure of 100 millimeters of mercury. Now, some people, this is normal for them. In fact, people who are otherwise healthy but have a low blood pressure tend to have longevity. They live for a very long time. If you are hypotensive and in addition to that have these symptoms like lightheadedness or fainting or lack of concentration, or if in the past you haven't been hypotensive and that's a relatively new situation for you and there's nothing that you have necessarily changed, at least intentionally, that may have caused that, then that might be a reason to see a physician, because there are some conditions, certainly malnutrition, hypothyroidism, and other situations that can cause hypotension. Okay, so I sent you this learning activity. And I wanted to go over this with you before moving on, right? So hopefully you did this. And all right, so we want to start with the equation for blood pressure, which is BP, blood pressure, equals cardiac output times peripheral resistance. All right. And then I suggested that you label this figure here because I think this figure does a absolutely wonderful job of illustrating all the different factors that can affect blood pressure, right? And so this is cardiac output, of course, right here. And this is blood pressure. It is, right? Hopefully everybody did this, and I'm not telling you anything you didn't already know. I'm just confirming what you thought you knew already. And then this over here would be what? Peripheral resistance. And peripheral resistance is basically the resistance to blood flow, right? Most of which is provided by your arterioles. Okay, now let's see, I don't know if I can do, how quickly I can do this, right? But let's look at how these different factors affect. See if I can put this down. So, all right, so I still think we're okay on time, right? I won't guarantee that I'll be able to finish all of this, but we'll at least start. All right, so increased heart rate. How is that going to affect cardiac output? Well, of course, it's going to increase cardiac output. It's also going to affect peripheral resistance, but the biggest effect is going to be on cardiac output. So the net effect is it's going to increase blood pressure. You can't affect cardiac output without affecting peripheral resistance. Okay, so I just want to put that out there. So, but I'm going to highlight these two factors, cardiac output and peripheral resistance, is affected the most. All right, what about hemorrhage? How's that going to affect cardiac output? Well, if you have less blood returning to the heart because it's spewing all over the floor, right? That's going to decrease cardiac output. It's also going to decrease peripheral resistance because there's less blood being resisted. And so that's going to decrease blood pressure. That's the biggest fear with losing too much blood. Your blood pressure can drop to dangerous levels, right? That's why if you lose more than a third of two-thirds of your blood, your heart's not able to maintain sufficient blood pressure. What about dehydration? Well, same thing. There's going to be a decrease in cardiac output. It's also going to be a decrease in peripheral resistance, and there's going to be a decrease in blood pressure. Oop. All right, what about a increase in blood volume? Increase in blood volume, what's that going to do to cardiac output and peripheral resistance? Well, it's going to increase both, right? In fact, if you are dehydrated, they give you fluids, which increases your blood volume. Or if you've lost too much blood, they give you a transfusion, the point of which is to increase blood volume in order to increase your blood pressure. So that here, blockage to a major vein. Well, if there's a blockage to your inferior or superior vena cava, how's that going to affect cardiac output? Well, it's going to decrease venous return. That's what's returning to the heart, so that's going to lead to a decrease in cardiac output and therefore a decrease in blood pressure. Opening of calcium channels. How's that going to affect cardiac output? Well, it's going to increase it. How's it going to increase it? Well, the calcium channels on the cardiac muscle cells are going to open, allow more calcium into the cardiocytes. So you're going to have the heart beating harder, and that's going to increase cardiac output, and that's going to therefore increase blood pressure. And the opposite, of course, is going to cause a decrease in cardiac output and a decrease in blood pressure. What about vasodilation of arteries? So if the arteries get larger, what effect is that going to have on cardiac output and peripheral resistance? Well, it's going to increase stroke volume. It's also going to decrease peripheral resistance. And the bigger impact is going to be on peripheral resistance. Right? It's going to decrease peripheral resistance. And if it's going to decrease peripheral resistance, even though it's increasing cardiac output, the bigger effects on peripheral resistance is going to decrease blood pressure. That's why alcohol tends to lower blood pressure, because it causes vasodilation. Vasoconstriction, of course, it's going to have the opposite effects. Vasoconstriction is going to increase peripheral resistance, and therefore it's going to increase blood pressure. Again, go back up to this figure up here. If we increase peripheral resistance, that's going to increase blood pressure. Decrease peripheral resistance, it's going to decrease blood pressure. And then lastly, what if we had scar tissue on the linings of the arteries? How might that affect cardiac output and peripheral resistance? Well, it's going to be greater resistance to blood flow. Remember that the lining of the blood vessels is very, very slick, shall we say. It's a very low friction surface that the blood interacts with. So if we change it, like we put scar tissue, I'm sure you've seen scars before, right? They're not smooth at all. So scar tissue is going to increase peripheral resistance, probably decrease cardiac output somewhat, if at all. And the net effect is it's going to increase blood pressure. That's why you find with cardiovascular disease, where there is arterial sclerosis or atherosclerosis, both are changing the lining of blood vessels. You tend to see an increase in blood pressure. Are there any questions about these different factors and how they affect either cardiac output, peripheral resistance, and blood pressure. And again, all of these affect cardiac output and peripheral resistance. These two are related. You can't affect one without the other here. What I tried to identify is where the greatest impact would be, and ultimately how it would affect blood pressure. So, questions? Don't be shy. Okay, well, if there are no questions, we're going to now cover the last topic of the cardiovascular system. Okay, and I'm going to go slow and methodical through this topic because it can be a little confusing for students, but I believe that if the way that I teach it and the way I go step by step through it, that everyone can leave today having a basic understanding of capillary exchange. And also, Emily, you asked by email a question about this, and I said, hey, we're going to talk about that today. This is the time. So we're going to describe the 4 ways in which substances move across the walls of the capillary. We're going to describe bulk flow. And we're going backwards. Alrighty, so recall that capillaries form a network of blood vessels among tissues. They are, it is across the wall of the capillaries that substances move between the blood in the capillaries and the tissues. Okay, oxygen and nutrients go from inside the blood vessel to the interstitial fluid, and then substances like carbon dioxide, metabolic wastes leave the cells, enter the interstitial tissue fluid, and then move across the walls of the capillary into the capillary. Capillary exchange is this movement of substances across the wall of the capillary. So what we're looking at now is how do these substances move across the wall of the capillary? That is what capillary exchange is all about. How does this occur? So let's look at that. So there are 4 basic routes by which substances move across the wall of the capillary. First, some substances can just simply diffuse across. Okay, they can just diffuse across. Now, before we go any further, what is the wall of the capillary composed of? It's composed of a single layer of squamous epithelial cells and a basement membrane. So what's going to determine what substances can diffuse across that layer of simple squamous epithelial cells? Well, it's going to be the plasma membranes of those simple squamous epithelial cells. And what can simply diffuse across the plasma membrane? Think about that for a second. If you said carbon dioxide and oxygen, the respiratory gases, and hydrophobic or nonpolar substances, you are correct, right? The substances that can diffuse across the plasma membrane are the substances that can diffuse across the wall of the capillary, right? Because basically they're having to cross the plasma membrane in order to get into or out of the capillaries, right? So lipids, respiratory gases, they just diffuse right across, right? Carbon dioxide diffuses out of the capillaries across the plasma membrane, and oxygen can diffuse into the blood of the capillary across the walls of the capillary, okay? Other substances can cross by endocytosis and exocytosis, right? Endocytosis on one side of the cell to be taken in, and then exocytosis on the other side of the cell, right? And let me show you that here, right? So what you're looking at is a image similar to what's in your book, just to sort of orient you. This is the lumen. This is the hollow space of the capillary here, where it says lumen. This is the wall of the capillary here. So these sort of purplish holy looking things are supposed to be simple squamous epithelial cells, right? And then out here, the blue is the interstitial fluid. So some substances just diffuse right across, carbon dioxide, oxygen, lipids. Other substances can enter one side through endocytosis and exit on the other side through exocytosis, right? Your book doesn't use the term, but it's the process is called transcytosis, but it's basically endocytosis on one side, exocytosis on the other. It's like you enter, if you want to get to the backyard, you can go through the house by entering the front door on one side and then exiting the back door on the other side, and you're in the backyard, right? Sort of like that, okay? The third way by which substances can move across the walls of a capillary are through what are called intercellular clefts. So some capillaries, not all, but some capillaries have spaces between the simple squamous epithelial cells. And those are called intracellular clefts, and substances can just simply move between them, right? Fluid and whatever's in the fluid can move between them, right? Like walking between two houses, okay? Now, not all capillaries have intracellular clefts. In the central nervous system, you have the blood-brain barrier where you have the least permeable capillaries in the entire human body. They don't have intercellular clefts. And that's because you have tight junctions between the cells. So nothing moves between them. So not all capillaries have intracellular clefts. Many do, but not all. In some very permeable capillaries, we even have large gaps or pores called fenestrations. And they allow a significant amount of movement of substances between the endothelial cells because there are large gaps there, okay? You find fenestrations in capillaries where there's a lot of secretion or absorption occurring. For example, you would expect to find intestinal capillaries that are responsible for absorbing nutrients from your small intestine. You would expect them to have intercellular clefts, or I'm sorry, you expect them to have intercellular clefts and fenestrations. Also, around endocrine organs like your thyroid glands or your pancreas, capillaries found there, I'd also expect to find capillaries with large fenestrations. Okay? Now, I want to focus on these fenestrations and these intercellular clefts, because what's moving between these intercellular clefts and these fenestrations? Well, it's fluid, right? It's basically the plasma of blood, and it's the fluid in the interstitial fluid. So what we want to talk about now is, well, what determines which way that fluid goes, right? What determines if the fluid moves from interstitial fluid to the lumen of the capillary, or from the lumen of the capillary to the interstitial fluid? And when I talk about these fluids, understand that these fluids have all types of solutes in them, right? They've got ions, they've got glucose, they've got amino acids, etc. Okay? That movement of fluid across the wall of the capillary, in those intercellular clefts and in those fenestrations, is referred to as bulk flow. So it's the movement of fluid across the capillary, right? So going back to this image here, the movement of fluid here at the fenestrations and the movement of fluid here at the intercellular clefts, that is referred to as bulk flow. There are two primary forces that act on that fluid. One is osmotic pressure, and the other is blood pressure. Osmotic pressure tends to drive fluid into the capillary, and blood pressure tends to drive it out of the capillary. Now, this is an image that's not in your current book. It was in your old book, but I like to use it because I think it does a really good job of illustrating bulk flow. So this is a capillary. Movement of blood is from the left side to the right side. So the left side of this capillary is the arterial end. And although not shown here, you have arteries feeding this capillary with blood on the left side. On the right side is the venule end. You would have veins draining the capillary on the right side. I want you to notice here at the top, the blue arrows which illustrate blood pressure. Blood pressure tends to force fluid out of the capillary. And so you see that these blue arrows are pointing out, away from the capillary. Blood pressure tends to drive fluid out of the capillaries, as I state above. Osmotic pressure tends to pull blood, or drive fluid rather, into the capillaries. And they're shown by these, I don't know, pinkish, purplish, whatever, arrows that are pointed into the capillaries, right? So it's those two forces opposing one another that determines if there is net flow of fluid out of the capillary as occurs on the arterial end of the capillary, or net flow of fluid into the capillary as occurs on the venule end. Okay, so this is a summary of what occurs. Let's look at the details. If you look here, what you see is that there's net movement out on the arterial end, and there's net movement of fluid in on the venule end. Now let's look at why that happens. First, I just want to make sure everyone understands what osmosis is. Osmosis is the movement of fluid is the movement of water from low concentration to high concentration. And as that water moves, it creates a force, which we call osmotic pressure, right? So if you recall, if we put a container containing just pure, saline solution into a drum that contained pure water, that pure water is going to move into that drum, and so the column would rise here. What you're seeing is water moving from low concentration to high concentration. That's osmotic pressure. In the capillaries, we have plasma proteins, especially albumin, and they stay in the plasma, so they will always draw water into the capillaries, right? That's the osmotic pressure. Blood pressure is the pressure that the blood exerts against the walls of the capillaries, right? It's not any different from the pressure of water in a garden hose. If you turn a garden hose on, turn the water on, and you were to go and punch holes in the water hose, the water spurts out. Why? Because the pressure inside the hose is greater than the pressure outside of the hose. Okay? All right, let's go back to this figure. So on the arterial end of the capillary, blood pressure is about 35 millimeters of mercury. Osmotic pressure pulling in is only 25 millimeters of mercury. And so there is a greater force pushing out than pushing in. And so there's net movement of fluid out of the capillary, which is referred to as filtration. As we go from the arterial end of the capillary to the venule end of the capillary, look what happens to blood pressure. It drops from 35 millimeters of mercury to 17 millimeters of mercury. Osmotic pressure remains the same. So now on the venule end, we have a greater pressure pulling water in, or fluid in, than there is pushing fluid out. So there is net movement of fluid into the capillary. So that's what's happening in the capillary. We have, and that's called absorption. So we're having filtration on the arterial end, absorption on the venule end. And do you see how this helps mix and refresh that fluid, filtration on the arterial end, reabsorption on the venual end. Now I'm going to reference an image that is currently in your book, and so I'm going to compare, or I'm going to connect the image I just showed you, which is no longer in your book, to this image that is in your book, right? And if you look here down at the bottom, here you see this graph. If you can explain this graph, you understand bulk flow, okay? Here you have this artery, this capillary here at the top. On the left side, this is the arterial end. On the right side, you have the venual end. Here at the bottom, blood pressure here is greater than osmotic pressure on the arterial side. So osmotic pressure remains the same across the capillary. Blood pressure starts higher than osmotic pressure on the arterial side. So we have pressure pushing out, then pulling in, and so we have net movement of fluid out of the capillary, or what's referred to as filtration on the arterial side. As we move from left to right across the capillary, blood pressure falls, and in fact, it falls below osmotic pressure. Now there's a greater force pushing or pulling fluid into the capillary on the venual side, and so we have reabsorption here. Okay, if you can explain this figure here at the bottom as I have, you understand bulk flow or capillary exchange. Okay, now I don't know if you noticed this, but do you notice that the fluid pushing out is 10 millimeters of mercury, and the fluid pulling in, the pressure pulling in, is -8? So obviously there's a slight imbalance. We have a little more fluid leaving the capillaries than enters, and that's where the lymphatic system comes in, and it basically picks up any excess that's not reabsorbed. Okay. Alrighty, so I do know we're at the end here, but I just want to talk a little bit about developmental aspects of the cardiovascular system. It's just a couple of slides, and then we'll be done, and we will have covered everything that's going to be on your exam. So we're going to describe the development of the cardiovascular system during pregnancy and its implications, and describe the effects of the cardiovascular system that occurs with age. So very early on in gestation, by the 4th week, you have a tube heart, okay? That tubed heart is fully formed into a 4-chambered heart by 7 weeks of gestation. So that's just about a month and a half. After that, it just gets bigger, right? That's all that occurs. Now, because it's forming so early during gestation, if there is anything that the mother has taken internally, any drugs or whatever, legal or illegal, prescription or over the counter, that interferes with the development of the heart, it can occur before she even knows she's pregnant. So anyone who is engaging in sexual intercourse without contraceptives should be aware of anything that they are taking, that they are exposed to, and its potential impact on the development of embryo, because damage can be done before the mother even knows she's pregnant. Okay, congenital heart defects account for about half of infant deaths resulting from congenital defects. Congenital just means prior to birth. Okay. As we get older, what happens to the cardiovascular system? Well, unfortunately, nothing good, right? There is a general loss of elasticity of our blood vessels, specifically our arteries, so they don't stretch and recoil as well. This is referred to as arterial sclerosis, or hardening of the blood vessels, or the hardening of the arteries, I should say. There is, in general, a risk of hypertension and heart disease that occurs as we get older. A lot of that is because of the loss of elasticity. There's an increase in risk of the buildup of lipid deposits on the walls of our arteries, which is atherosclerosis. And atherosclerosis, those plaques often are the result of this continuous cycle of damage, inflammation, and repair. Damage, inflammation of repair. And this is what changes the structure of the walls of the arteries, increasing peripheral resistance and blood pressure. And these plaques can partially or completely occlude or block an artery, and if they can spark or spawn a thrombus, which then can break off and become an embolus. Okay. All right, so that's all I have for you today. I did not get to the digestive system, so the expectation is on Friday we'll cover overview of the digestive system, and we'll also cover the oral cavity, pharynx, and esophagus, and then over the weekend you'll be knocking out the stomach and the anatomy of the small intestine. Thank you so much for your attention and attendance. Trying to get it out there. I'll open the floor up for any questions that anyone may have. Okay, question about the final as listed on your study guide syllabus has indeed been pushed back, and it has been pushed back to May 22nd. So it's going to open Wednesday, May 20th, and it's going to close Friday, May 22nd. So yes, it has definitely been pushed back. And as I mentioned at the beginning of the our return to class online, I do realize some of you may have made plans right after the semester was supposed to end, and so if you need to take the exam early, that will not be a problem.